So good morning, everyone. We're going to go ahead and get started. Thanks for hanging out for a few extra minutes. We're just fixing some adjustments here on our side. But thank you all for joining us on behalf of the Sparkman Center. I'd like to welcome you to our first Global Health Seminar. It's nice to see some faces in person as well as over Zoom. Just for our people attending on Zoom, a few little housekeeping things. We are going to be recording this, so please just be aware of that. Also, if you have any questions, please feel free to utilize the chat box at any time. I'm going to join on Zoom, so I'll be checking that and monitoring that. So yeah, I think that's it. And I'm going to turn it over to Dr. Janet Teran, our Sparkman Center Director, to introduce our speaker today.
Hi, everyone, and welcome. It's great to see that the Sparkman seminars are getting started for the year, and really my pleasure to introduce my friend and colleague, Dr. Lynn Matthews. And Dr. Matthews is an associate professor in the Division of Infectious Disease at UAB. She's also the director of Global Infectious Disease Research. And also she's the associate director for the Mary Harrison Global Health Institute in the School of Medicine. So very integral person for global health at UAB. And she is a clinician-scientist focusing on infectious diseases. And she's had continuous funding from NIH since 2011 to develop and promote HIV prevention programs in the context of reproductive goals for men and women affected by HIV. She's done a lot of work in South Africa and Uganda, and now she's extended her work to Alabama as well. So we are very excited to hear about what she's been doing, and it looks like she's going to cover the scope of the globe in this presentation. So thank you very much.
Thank you, Janet, and thanks, Cameron, and thanks to the center for inviting me. Can you all hear me okay? Janet, my sound okay?
Yes.
So I'm going to talk about a couple of different projects promoting PrEP use for women in Uganda, South Africa, and Alabama. I do receive some operational support from Gilead Sciences. They do make TDF-FTC, which I'm going to be talking about. So I'm going to review HIV acquisition epidemiology for women planning for and with pregnancy, review PrEP efficacy data. This hybrid thing, I'm very confused where to look. I look confused, that's why. There's a camera for the Zoom people. You all are out here. My slides are here, but also here. So bear with me. I don't want to look there. I'm going to talk about the PrEP efficacy data that we have for women and some of the challenges with implementation of PrEP. I'm going to share findings from a couple of projects looking at perinatal PrEP use in Uganda and South Africa, and then dive into some of the work we're doing here in Alabama with trying to promote PrEP for Black adolescent girls and young women. And I'll talk about some of the similarities and differences across those contexts. So this is a paper that was published in 2018, capturing data from a bunch of different HIV prevention trials that were with serodiscordant couples in sub-Saharan Africa. So one partner living with HIV, the other one not, with HIV uninfected women being represented in these different prevention studies. And what they were able to show with this nice analysis is that the risk of acquisition for women in the context of condomless sex, controlling for viral load suppression in the male partner, increases with pregnancy and during the postpartum period. So this relative risk of 1 is during non-pregnant periods, and that goes up with pregnancy and postpartum periods. This is probably related to behavioral factors as well as biological factors, but this is the state of affairs for women who are exposed to HIV in early, late, and postpartum stages of pregnancy. And so that matters for preventing HIV among women. It also matters for preventing perinatal transmission. PMTCT, or preventing mother-to-child transmission, is a really important and well-funded global goal to try to eliminate mother-to-child transmission of HIV. And if you look at the cases of mother-to-child transmission in 2020, about a third of them happen in the context of women who acquire HIV during pregnancy or breastfeeding. The vast majority of the work of PMTCT programs focuses on preventing HIV transmission to an infant, starting with a woman who's living with HIV and pregnant. I think there's a lot of opportunities to do more by preventing HIV in the context of pregnancy and breastfeeding. So what are the different ways to minimize HIV transmission around conception and pregnancy? Here I'm focusing on what are the strategies of the male partners living with HIV. So treatment for him and viral suppression. If he's virally suppressed, he doesn't transmit HIV sexually. So that's a great strategy. That requires the male partner to test for HIV, engage in HIV care, remain in HIV care, take treatment, and adhere to treatment. All of which are steps that are challenging, have been particularly challenging for men in sub-Saharan African settings. PrEP, or HIV pre-exposure prophylaxis, is something that an HIV uninfected woman can take to prevent HIV at the time of conception. There's some other strategies that are a little more behaviorally complicated, like timing condomless sex to peak fertility, STI treatment, testing, partner treatment, and semen processing, where HIV is removed from semen, but that is quite complicated, not readily accessible. So I want to talk about how PrEP can be a solution. I actually want to back up and talk about the fact that, actually, I'll talk about the next step. So I want to talk about PrEP. So HIV pre-exposure prophylaxis does work for women as long as they can take it. So this is a meta-analysis that was published in JADES that summarized the different clinical trials that included women looking at PrEP efficacy. And what this analysis shows that if you look at these trials, if you organize the data by studies in which there was higher adherence, for the studies in which there was at least 75% adherence, the relative risk was decreased by about 60%. I'll also highlight here that for these studies that worked, so the ones on this side of the relative risk of one, most of these are studies with serodysphoric couples. So the male partner was known to be living with HIV, had disclosed to his partner, they enrolled together as a couple. In those studies, adherence tends to work pretty well. In the studies with individual women enrolled as individuals, not with their partners, the adherence challenges tend to be more profound. So PrEP works if you take it. How do you figure out if people are taking it? This is kind of how we think about adherence in the context of HIV treatment, where our gold standard is your HIV RNA suppressed. If you're HIV RNA suppressed, you are taking sufficient drug to do the job of HIV treatment. We don't have that easy of a biomarker for prevention. Knowing that you didn't get HIV is a little bit late in the game for knowing what's going on with adherence. So there's all these different strategies. Self-report pill counts are a bit more subjective. Digital pills, which is a new thing where there's a chip in the pill that gets taken that actually tells you if someone took their pills or directly observed therapy, is very objective. And then somewhere in the middle are things like electronic monitoring, electronic pill caps, or drug concentrations that tell you that someone is taking the pill. So for the PrEP adherence that I'm going to talk about, I'm going to mostly focus on electronic monitoring and drug concentrations. But you should know, as I present data of different studies and how they measure adherence, it's kind of all over the map, and it makes it, I'm going to make some comparisons of studies that use different strategies to measure adherence, but those are all imperfect comparisons. So the different pharmacologic measures of antiretroviral adherence also vary in what they tell you, what adherence period is being measured. So if you look at the level of tenofovir in someone's plasma, that tells you what's been going on with their taking of that drug over the past week. If you look at urine tenofovir, that's also about the past week. If you look at tenofovir diphosphate in dry blood spots, what that is showing you is the diphosphorylated tenofovir within the red blood cell. So that gives you a measure of how often they've been taking their tenofovir over the past 4 to 8 weeks. Differs a little bit based on metabolism, anemia, blood volume, lots of things, gender, sex, race, ethnicity, but it gives you a general measure. And it's kind of akin to hemoglobin A1C in diabetes, where we look at the glycosylated hemoglobin in the red blood cells. Hair is another expensive but really interesting strategy, where about 1 centimeter of hair reflects 1 month of adherence. So in the studies that I'm going to talk to you about, we looked at plasma, which gives you a pretty short-term look, and we also looked at dry blood spots. So adherence to PrEP for women has not been as high outside of the randomized clinical trial data. And here I'm showing you a couple of different studies that focused on pregnant women and adolescent girls and young women who were recruited again as individuals, not as partners, and attempted to implement PrEP or study PrEP in some way in the post-trial setting. And if you look at these data points, in this study in Kenya, about 12% of women came back for a refill at 6 months. In this study in South Africa of postpartum and pregnant women, about half came back for refills at 6 months. When you start looking at more objective measures like drug levels here and NIMH cap here, this is with adolescent girls and young women in Kenya. None of them had taken enough drug to be suppressed here. And in this study in South Africa, about 5% of women had drug levels consistent with protection at 12 months. So there's been a real challenge with how to support people to take daily oral PrEP, how to figure out what are the populations that can most benefit from this really groundbreaking strategy, but it only works if you take it. So this is an old slide from AVAC from 2016, which shows in these different clinical trials that informed the approvals for PrEP as HIV prevention, the effectiveness of the studies varied according to the percentage of participants that had detectable drug levels. So for those studies where 80 to 90% have protective levels, protection was 60 to 100%. Now, if I map out those effectiveness, demonstration, implementation projects that we just talked about, they're all kind of mostly low. Let me just finish mapping them for you. So this one, PrEP for postpartum and pregnant women, this is return to clinic data. So this isn't their drug level data, but about 50% came back at 6 months, giving you a sense that maybe PrEP is working for this proportion of people. But these other studies, it's not really working. So I and others have really thought a lot about maybe PrEP could work during periconception and pregnancy time periods. It's a motivated population that might have more time limiting PrEP needs. Taking PrEP for all of your sexually active life can seem a bit daunting. It's something that the uninfected partner can control. And particularly if the partner living with HIV or suspected to be living with HIV can't test or get into care or be virally suppressed, this is something the uninfected partner really controls. But the concerns have been around adherence. So I've been really fortunate to work with two research partners in rural southwestern Uganda and Mbarara University of Science and Technology, or MUST, and in urban Durban, South Africa, on the Indian Ocean coast with Match Research Unit. And it's been interesting to study my questions around periconception and pregnancy PrEP in these two contexts because they're quite different. So I already mentioned one's urban, one's rural, Uganda, South Africa. HIV prevalence is also really different. In South Africa, the HIV prevalence is quite high, about 18% for adults. In antenatal clinics, about 41% of women in Durban who present for antenatal care are living with HIV. The total fertility rate is 2.3, which is not so far off from what it is for the US, about 2.3 pregnancies per woman in her reproductive life years. Uganda, the HIV prevalence is a little lower, certainly much higher than in the US though, and it's 7%. Antenatal clinic prevalence is about 12%, but the total fertility rate is quite high with 5.7 pregnancies per woman during her reproductive life years. So it's been interesting to study my questions in two very different contexts. So I'm going to talk to you about a study that we did in South Africa that completed during the pandemic. I'm not going to embarrass myself or my Zulu friends by saying the Zulu term, but we abbreviate this ZINC, which means protecting yourself in pregnancy. And we enrolled uninfected women with personal or partner desires to have a child in the next year in Durban. They all reported, again, this is recruiting individual women. We didn't recruit couples, but the women reported they had a partner who was stable. He was either living with HIV or she didn't know his zero status. And we offered a whole package of safer conception strategies, including bring your partner in for couples-based counseling and testing. We can get them tested and on treatment. All of the strategies were offered, including daily oral PrEP with adherence support. And our aims were to look at PrEP use, including plasma tenofovir, which again is sort of used in the last week. And we also had NIMH cap data, which tells us how often they're opening their pill bottle. And then we did qualitative interviews to get a better sense of what strategies were working for the women and why. So this is a big team. My partners in Durban were the Match Research Unit, and the site PIs were Jenny Smith and Manjita Juggernaut. And Christina Saros, who's a behavioral psychologist at Mass General Hospital, designed and implemented and supported the PrEP adherence intervention. And this is our happy study team in like the pre-COVID days of February 2020. Manjita, site PI, Bongeka Kia here was the Safer Conception Counseling lead, and Mkulisi Machendra here, who our entire study affectionately referred to as the man because he was the only man. He led the adherence counseling support sessions, and Jenny Smith wasn't in this picture, but she was the site. So we enrolled 330 women into this study. Things I want to highlight here, there's actually a high level of education. About 40% of the women had completed some university studies. The majority had not had more than two or more prior pregnancies. Most had one sexual partner in the last 3 months. Most of them reported that the partner they wanted to have a child with was a long-term partner or boyfriend. And this was not our study design. We wanted to include women with unknown or known serostatus partner. 96% did not know the status of the partner with whom they wanted to have a child in the next year. 60% of the women who completed the Safer Conception Counseling sessions with Bongeka chose to use PrEP. And here I'm showing you the pill cap opening data over 12 months of follow-up. And what you see is that they start okay, and then they have challenges maintaining that adherence. So our median adherence over this full-time course is 63%, which doesn't mean a lot, but it does give you a snapshot. And again, I think I said this, should have said this. The estimate is that you probably need to take more than 80% of study drugs to be protected. So we enrolled women who were planning for a pregnancy. We had 35 women become pregnant, which is pretty low pregnancy incidence, which I'm not going to directly address, but happy to talk about in questions. But for women who became pregnant, looking at their pre-pregnancy adherence and their post-pregnancy adherence was pretty stable. Pregnancy didn't seem to throw them off of their adherence trajectories. This is a complicated slide, which I'm going to walk you through. What I'm showing you here is at month 3, month 6, month 9, and month 12, what their adherence looked like by pill cap in the yellow to gold, and by plasma tenofovir. Remember, that's adherence like in the past week, in the light blue to dark blue. The darker bars represent adherence that is sufficient to protect against HIV based on the data that we have. It's a little messy for women, but based on the data we have, these women in the adherence in the darker colors is likely to protect them. And so what we see is that women start out pretty strong, but then it becomes more challenging. So by 6 months, 9 months, 12 months, we see that fewer than 30% of women are taking, or around 30% or less of women are taking sufficient PrEP to adhere. Now, that's better than some of the studies we've seen. It's better than one of the adolescent girls and young women studies where 0% of people were taking more than 80% of their pills, but it's not quite ideal. In terms of HIV incidence, we saw 11 infections. None of those, fortunately, were during pregnancy. We didn't see any resistance mutations, and the incidence was much higher for the people who did not choose to take PrEP. Norma Ware, who's a medical anthropologist based at Harvard Medical School, and her team led the qualitative component for this study. So they enrolled 25 women into serial qualitative interviews. We did serial interviews to try to capture how their adherence experiences changed with time, as we know. So they enrolled people who had started PrEP within 3 months, and then they did follow-up interviews. They had trigger events for big life changes like a pregnancy or a new partner or a decision to stop PrEP or COVID. So basically everyone was eligible for a trigger interview, it turned out, and then an exit interview. And so some of the emergent themes were that disclosure of PrEP use is important for supporting PrEP use. Stigma of PrEP use is a big deal. Motherhood challenges impact PrEP use. A mobile lifestyle, COVID lockdowns, and partner proximity all had impacts. I asterisked COVID lockdown here because I think people who don't know what happened with COVID in other contexts don't know. So in South Africa, they didn't have a ton of COVID cases. They didn't have a ton of COVID death, but they had very extreme lockdown measures, which included, police patrolling the streets and people being afraid of getting beat up if they left their houses. So in terms of stigma, this interviewer asked this participant, have you ever thought about what others would say if you take this pill out? Yes, they would think it's ARVs. Even with my boyfriend, when I first came with these pills, he asked me what these pills are for. Why are they so big? What kind of pills are they? You see, I explained to him, these prevent HIV, not that they are ARVs. So in South Africa, HIV is so common. There's so much HIV that people are really quite familiar with what happens in HIV clinics and what ARVs look like. And so the stigma around ARV use for prevention is quite profound. Here, this woman talks about how having a baby has made it harder for her to take PrEP, which I can fully understand. It was a challenge. I take my pills at 8. You'd find that by that time I'm still sleeping because I would make sure that I sleep when the baby is sleeping because he wakes up at night. Sometimes I would wake up tired. I can't even do a thing. You would find that I end up not taking the pills. And here, these two quotes highlight how disclosure of PrEP use, despite the challenges around stigma, helped some women take their pills. He, my partner, reminds me about time. He would make a joke, not every day, but he'd say, you take pills. You haven't taken them today. I would say, you know, you just reminded me. Let me go and take them. And then this participant says, my mother used to help me with the pills sometimes. She would sometimes remind me, even when I'm not home, she would call and say, hey, it's time. You see, she's the one who's been motivating me to drink them. Partner proximity. So this is important. So this woman talks about how she doesn't see her partner all the time. I came back to Durban. Still, we were far from each other and we would not see each other for a whole month. I would think, since my partner's not around, why would I bother to take my pills every day? I'd say, okay, let me skip today. I'll take them tomorrow. With him absent, I saw there's no need for PrEP. I just thought, even if I skip today or if I'm not home, I don't feel guilty that, oh, I didn't take PrEP because my partner's away. I decided to stop. When he's about to come back, then I will continue with it. So this is participants talking about basically on-demand PrEP, which is a strategy that works really well for people with anal exposure to HIV. The PrEP levels accumulate in rectal mucosa and it makes it possible. So on-demand PrEP works really well for MSM, gay and bisexual populations. It doesn't work for women with vaginal exposure because it takes at least 7 days, probably more like 20 days for women to accumulate enough drug in vaginal cervical mucosa to be protected. The lockdown, this woman says, since there's been lockdown, I was locked. One was locked inside the house. One was always in the house. PrEP was close by. It helped me. One was doing everything in the house. But then this woman says, when the lockdown started, I don't know what made me lazy, but I just said, no, I'm now tired of taking pills. And then this mobile lifestyle, I'm not going to read these for the sake of time, but basically people move around a lot, and moving around with a big clunky bottle with a big MEMS cap on it is challenging for people to remember to do, especially when they're concerned about stigma of ARV use. So some conclusions from this work so far in our analysis: the periconception period is a really high risk period for acquiring HIV. There's interest in and acceptability of periconception PrEP among this population. Our patterns of adherence and some of our qualitative findings highlight that women will need different strategies for PrEP, different kinds of adherence support. Method choice that accommodates a mobile lifestyle and ARV-related stigma will be important. So that gives us optimism for things like long-acting injectable PrEP. One of our next steps for this is a project being led by postdoctoral fellow Dr. Shea Suhumwa, who works with me here at UAB. She has this UAB CFAR pilot project looking at injectable cabotegravir PrEP in South Africa, looking at acceptability and feasibility for postpartum and breastfeeding women. And we have a lot of other projects planned around this, but I'm going to move on and transition to telling you about a very similar study and what we found in Uganda. So again, rural southwestern Uganda, where HIV prevalence is a bit lower, total fertility rate is quite high. So this was the Healthy Families PrEP Clinic program. And we asked, how do HIV exposed women use periconception PrEP? We recruited a similar population of women to the last study, uninfected women, personal or partner plans for pregnancy in the next year with a partner known to be or likely to be living with HIV. We saw them quarterly, offered comprehensive safer conception counseling, inclusive of PrEP, and had an adherence protocol to support PrEP use for people who chose to use it. Here we looked at the uptake, we looked at adherence. This is a different kind of electronic pill cap. It's called a WISE pill device. And we also have plasma levels. And in this study, we also had dry blood spots. And we also conducted qualitative interviews. This time we did one-time interviews, but we also included partners in those interviews. So our partners for this study at Nimbara University of Science and Technology, Dr. Bosco Bwanga was the site PI, and Dr. Esther Adekunda led the qualitative work. Again, Christina Saros from Mass General led the adherence support intervention. And here's our team in November 2019. I'll highlight also the Deo Tukwasibe pictured here was the lead counselor for this project. He conducted the safer conception counseling as well as the adherence counseling. And for this study, it's a little bit smaller, 131 participants, a little bit older, 28.7 was the median age. Most women had had a couple of prior children. Most had one sexual partner again. The vast majority, their pregnancy partner was someone who was a spouse or they were living as married. And most knew their partner status, and most about 3/4 had a partner living with HIV. Only about 1/4 had an unknown serostatus partner. Only about 1/4 is a lot, but just compared to our South Africa data, it's different. And most of the partners living with HIV were accessing treatment, and mostly they were having condomless sex. Here, our PrEP uptake was quite high. 90% of women chose to use PrEP. And looking at 9-month follow-up, this was a shorter study. 9-month follow-up, the percent of days with pill cap openings was all above 80%. They were really able to take it quite well. And when we looked at the similar figure of what happened pre-pregnancy and post-pregnancy for the women who were taking PrEP before they got pregnant and continued it post, they maintained very high adherence. We also had a much higher pregnancy incidence, which goes along with a very different total fertility rate in Uganda. We had a lot of pregnancies here. Okay, this complicated but interesting to me, at least, slide again, looking at their adherence trajectories, their adherence based on pill cap data, plasma tenofovir, so that's adherence in the last week, and dry blood spots showing diphosphorylated tenofovir at 3 months, 6 months, and 9 months. What we see here is higher adherence overall. There's a bigger discrepancy here between what we see in the pill cap and what we see in the drug levels. You know, it's very hard to fake pill cap use because, you know, it's as hard as it is to take a pill every day. It's also hard to remember to open a pill cap every day. So we're still really struggling to try to understand this. It does seem like, you know, for the purposes of thinking about did our intervention work or not? Yes. And if we take the more conservative estimate, it's that, you know, at 3 months, between 60 and 70% of people were protected based on drug levels, between, you know, about 60% also at 6 months, and between 50 and 60% at 9 months. So I think our adherence intervention worked well in this cohort. The discrepancy here, I think we don't know. We're still trying to understand. There's a lot of different things that impact your plasma level, that impact your dry blood, the tenofovir diphosphate, BMI, hemoglobin, race, ethnicity, pregnancy status are just some of the things that seem to matter. And we have pretty limited data for women about what cutoffs to use. HIV incidence in this study, we had one participant who did test positive for HIV at her 9-month study visit. She had access to PrEP, but her drug levels were not detected at any of the time points. So our HIV incidence was there, but not as high as in our South Africa study, which again makes sense based on the context and the networks. None of our pregnant women seroconverted. For this qualitative study, Dr. Esther Adekunda, who's at Embara University of Science and Technology, led this work with support from Maura and Owen Babazi and Madeline Pratt. And here we did in-depth interviews with 44 women, and we selected women based on their pill cap adherence data to select women with a variety of adherence experiences, as well as women not accessing PrEP. And we also recruited 7 of their male partners to talk about their experience with a partner using PrEP. Here, in terms of community, couple level, and individual factors that impacted adherence, it was really important for women and their partners to meet these cultural expectations to have a child and to preserve their relationships, which culturally kind of requires having children in order for the relationship to stay intact. They also really appreciated interaction with supportive healthcare providers. At the couple level, again, we had some men. They talked about the shared goal of trying to have a child, trying to not infect the partner, not living with HIV, and that having the uninfected partner kind of in charge of the prevention for a change instead of it all being on the partner living with HIV was really helpful for their relationship and improved a lot of their emotional support. At the individual level, women really were motivated to have an uninfected child to prevent HIV transmission in their partnerships and appreciated that they were in control. They didn't need to get their partner to be suppressed. There were barriers around the stigma of living with HIV and therefore PrEP use, the stigma of being in a sero-different partnership. So having a partner living with HIV while you are not living with HIV, people talk and think maybe you should be making different decisions. And so taking PrEP can expose that. There was barriers around non-disclosure of PrEP use and gender-based violence and individual level things like you don't want to take pills with your well. I'm not going to share quotes from that qualitative work for the sake of time. So our conclusions from this study are that HIV exposed women in Uganda who plan for pregnancy choose to use PrEP as part of safer conception care and use it quite well. By electronic pill cap, most are able to really achieve that greater than 80%. Our drug level data, we're still playing with it to try to understand it, but if we just interpret it very conservatively, 40 to 70% of periconception PrEP users were able to sustain adherence to PrEP. It didn't show you our pregnancy drug level data in either study because interpreting the drug levels in pregnancy is quite complicated. Not ready to present that yet. So again, we keep saying context matters. So we have different HIV prevalence rates and fertility rates in these two settings, and we saw very different PrEP uptake and use. The age was different. The marital status was different, and knowing partner status was really different. In Uganda, 75% of the women participating knew they had a partner living with HIV. Also, Department of Health guidelines and Ministry of Health guidelines in the two settings were different. When we did the study in Uganda, the Ministry of Health had already approved PrEP for use in pregnancy and for people planning for pregnancy. In South Africa, it was contraindicated because they wanted more data about PrEP safety. So we were able to do it in the context of a research study, but the guidelines were that it was contraindicated. That did not come up as a barrier in our qualitative work, but I think it did change the way our study operated because we were basically conducting a trial of a new drug for an unapproved indication. So again, this kind of line graph of looking at percentage of participants with detectable drug levels and efficacy in the clinical trials. So if I map our studies here, so the Healthy Families PrEP study in Uganda, by MEMS cap we're here, by drug levels we're more like here. The zinc study we're more like here. So the Uganda study suggests maybe this is a good population in which to have PrEP use confer efficacy. And there's two other safer conception studies that I didn't mention earlier because they are with serodiscordant couples, not with individual women. But this study, which was conducted by Renee Heffron in Kenya, was a small serodiscordant couple study among the uninfected women who were choosing to have a pregnancy with a partner living with HIV. 81% had high adherence by pill cap. And in this study by Ashley Leach, which was conducted with, again, a small set of serodiscordant couples in Boston, 87% of the uninfected women planning for a pregnancy had detectable levels of tenofovir FTC at 6 months, suggesting maybe this population really is a key group for implementation of PrEP. Okay, in the last couple of minutes, I'm going to change gears and talk about how that work has kind of impacted my work in Alabama. So I moved to Birmingham. I came to UAB in 2019, January 2019. And that time period coincided with the US launch of the federal Ending the HIV Epidemic Initiative. And this map shows the counties and then the states that are focus areas for phase 1 of this work to try to reduce HIV incidence by 2023. And so moving from, I was in Boston up here where there's a lot of CFARs and not many places with a lot of HIV to a place like Alabama where there's a lot of HIV and not a lot of people doing the work meant that I changed my focus to thinking about domestic HIV. So HIV disproportionately impacts Black women in Alabama. The rate of Black males living with HIV is 5.3 times that of white males. For women, Black women living with HIV, the likelihood of living with HIV is 10 times higher than for white counterparts. And if we think about new HIV diagnosis in Alabama, it's mostly among young Black people. So this is 2018 data. This shows of all the people newly diagnosed with HIV in Alabama in 2018, 72% were Black, 30% were 13 to 24 years of age. This is from CDC Youth Risk Behavior Surveillance data from 2019, surveilling Alabama high school students. 40% were sexually active, about half not using condoms. About 20% had ever been tested for HIV, and about 20% had ever been tested for an STI. So this population is at risk for HIV, not getting tested, and also not getting access to PrEP. So PrEP is widely and wildly underutilized in Alabama. This is the total number of PrEP users in Alabama based on pharmacy data. In 2019, about 2,500 people, and most of those are men, and most of those are not in our 13 to 24-year-old age group. Tends to be older white men who get access to PrEP nationally, and then wherever there's less PrEP, the disparities become greater. So I worked with people who had great community collaborations in Alabama already on a CFAR ending the HIV epidemic funded supplement to think about how to promote PrEP use among adolescent girls and young women in Alabama. We interviewed providers and youth, and this is our study team. And Dr. Samantha Hill, who's an adolescent medicine specialist and an early stage investigator now with NIH. She just had a K-23 funded in the past couple of months. She led the work with the provider funders. And what we're showing you here is that some of the main themes that lead to providers not prescribing PrEP to adolescent girls and young women relate to stigma. So there's stigma around HIV. There's stigma certainly around minority sexuality identities and gender identities. There's also a lot of stigma around like cisgender heterosexual people having sex. Just people having sex, there's stigma. So that makes it hard to talk about HIV. We also found a lot of limited knowledge and comfort with PrEP guidelines for adolescents, which makes it hard for providers to talk about it. And then there's a lot of healthcare systems and structural barriers that impede PrEP access for use, like being underinsured. Do you have insurance and explanation of benefits that go to your parents' house? And maybe they wonder, why are you getting STI testing? Why are you getting counsel about HIV prevention? Challenges with the Cures Act, which makes it possible for all parents to access their children's healthcare records. So a lot of major systems barriers and legislation in our state that makes it difficult for any sexual education to happen in public school settings. Madeline Pratt, who received her MPH here at UAB, led the client interview analysis. We had pretty small numbers in part due to trying to do this remotely during a COVID pandemic. But what they told us was very aligned well with what we heard from the providers. So the adolescent girls and young women who we talked to, they felt like a lot of different kinds of stigma made it hard for them to have frank conversations with their providers around sexuality, around any sexual activity, and around their race and their gender. They felt like they were stigmatized for being Black women having sex and talking about it with a provider. Therefore, the discussions about sexual health are not optimal in school settings or healthcare settings, or even at home. And so they seek information from other sources like their peers or the internet or social media. What we also learned in our interviews was that Black women have really learned to advocate for themselves in the healthcare setting, or at least those who chose to participate in our study. They have had negative healthcare experiences. Their peers have had negative healthcare experiences. Their mothers, their aunts, their whole community of Black women has had bad healthcare experiences. So they have learned to navigate and motivate. And they told us a lot about how they motivate for contraceptive care, how they motivate for STI testing, but they can't motivate for PrEP because they don't know it's an option, because the only thing that they know about PrEP is what they see on TV and in magazines. And so it looks like it's for white, gay, and bisexual men. It's not for them. They don't know about it. So that makes it challenging for them to motivate to access PrEP. So a follow-up study that we're doing informed by that work is an R34 that Letitia Elopre and I are multi-PIs on. So an R34 is a funding mechanism to develop and pilot testing and intervention. So we are developing and pilot testing and intervention to train and support family medicine providers to promote PrEP for adolescent girls and young women in the Deep South. We decided to do this with family medicine providers because it turns out they provide like the vast majority of rural care in this country to adolescents. So we wanted to work with them. UAB also has a great family medicine program with lots of programs across the state. So it turned out to be a really great partnership. So we're adapting content to train providers on HIV epi so that they understand that Black women are at risk for HIV, PrEP, what it is, how to prescribe it, how to get around a lot of different structural barriers to prescription and follow-up, how to take a sexual history confidently and comfortably. And we're also designing a program that supports PrEP champions at the clinic so that everybody has someone they can kind of lean on who knows about PrEP. So we'll test it, we'll pilot test it, and then if it works in terms of increasing STI testing, increasing PrEP prescriptions, and some survey data from adolescent clients about their satisfaction with their clinical encounters, then we'll look at how to maybe implement this more widely. One of the things I really like about this project is we have some kind of education specialists who are part of this. Brooke Hubner and Nick Van Wagner both think a lot about medical education, so they're helping us with this as well as adolescent providers, HIV providers, and behavioral health folks. Letitia Elopre and I are also MPIs on an R01 that was just funded in the past couple of weeks, where we are funded to develop a cohort of 18 to 50-year-old women in Alabama who have a recent syphilis or gonorrhea diagnosis. And the goal is to follow them longitudinally using an app, a health empowerment app, which Lisa Hightower-Weidman developed. The app has things like support for people, education, medication and health trackers, connections to peer navigators, other women in the cohort, etc. So we're going to adapt this. App has been really successful with adolescent populations. And mostly men. We're going to adapt it with a community advisory board to work for women in Alabama. We'll enroll the cohort, look at retention, and we're partnering with the Alabama Department of Public Health to use a program that they have developed in collaboration with Binks, which is a company that does home-based STI and HIV testing. So women will be able to enroll in the ADPH program, do home-based HIV and STI testing and quarterly questionnaires, all kind of within this app. They're not going to be coming in for study visits. They're not going to be coming into the clinic. And we want to look at what are some of the mediators and moderators of STI, HIV incidence, and PrEP use and PrEP uptake. And we hope this is not purely observational because the app is a bit of an intervention in and of itself, but we hope this will give us more information about how to better support PrEP use and other HIV prevention strategies for women. So PrEP reach to populations that need it has been really limited, especially for women. HIV incidence is high during periconception and among Black adolescent girls and young women. I've shared with you how women really do use periconception PrEP, and they mostly use it quite well. There's more work to understand what adherence support is needed for whom and when. And here in Alabama, our work to promote PrEP really does require multi-level interventions, getting at individual level factors like marketing so that women know that PrEP is an option for them, helping providers, maximizing what education and training providers have, addressing stigma around sex and sexuality in communities. And then like on the systems level, like the US healthcare system just is kind of a disaster, and PrEP highlights how and why. And the way sexual health teaching is regulated in schools is a problem. Newer PrEP options like long-acting injectables, every 2-month injectable cabotegravir is very effective. And we'll address some of the challenges. You still have to go to clinic, you still have to engage with the provider, you still have to have it offered to you, still need to do follow-up STI testing, follow-up HIV testing. So some of the pieces of I think the newer PrEP options really help with the daily oral pill taking barrier, but it doesn't totally fix all of the other challenges, which is why we need to move kind of quickly to implementation science to figure out how to get injectable PrEP and other PrEP modalities implemented. So I'll thank the participants, patients, families who contributed to the work, funders, my UAV support team, Brittany Martin, Tricia Smith, Jamie White, and Madeline are my kind of administrative support team that make it possible for me to do the work I do. And Dr. Bosco Buana, who we lost in 2020, who was an amazing investigator, and friend. But I'm very grateful for all that he did for this work. I cry every time I do this, but I still acknowledge him. I'm going to stop and thank you guys and I think we have a little bit of time for questions. And I'll stop sharing.
I'll start with a question.
Okay.
So
Can you all hear Cameron's asking? Sorry, I'm going to recover for a second. Can you all hear Cameron online?
Yes,
Okay.
yes, we can hear her. Yes.
So obviously there are a lot of issues in Alabama and states like Alabama with sexual education in schools. Like I went to high school in Alabama, that's why abstinence only. So how do you even begin to touch that. Especially like you showed the map of CFAR centers. There's like, very limited in Alabama, yet the HIV rates are extremely high. How do you even start to go about adolescent sexual health when there's the policy in place and barriers to begin with?
Yeah, that's a great question. I definitely do not know the answer. What I have learned from this work with adolescent health and collaborating with a lot of adolescent medicine providers is that adolescent medicine providers are doing tons of advocacy all the time. I think that our adolescent colleagues here, the adolescent medicine colleagues here at UAB have been front and center in advocating for transgender health, and they've been advocating for sexual health education. They do it all the time. I don't know how they find the energy or the time, but they do it. It's part of their job. I think they see that. I think that I really don't know the answer to that question. I think it comes from kind of sharing our science with communities, and the advocacy has to come from communities. I think that if COVID taught us a lot of things, including that like public policy people aren't really that interested in hearing from scientists, but they're interested in hearing, I think, from their constituents and from their communities. And so I think it has to be us doing a better job of communicating science to communities, and then they need to advocate for the change, and we support that.
Yeah, and taking out the maybe more religious and political aspects of it and just going at it with science to community.
Maybe, yeah.
If I can ask a question, that would be great. Thanks, Lynn. That was a great presentation. Really, really amazing work. So in a couple of weeks, I'm attending a workshop, NIH workshop on reciprocal innovation, global health, reciprocal innovation. And I think your work would be like so amazing for that workshop, actually, but I'm just wondering your thoughts on what you learned in your work in Africa that kind of helped you take the work forward in Alabama, and is there things you're learning in Alabama that you kind of want to take back to the work in Africa? Is that reciprocal innovation going on?
Yeah, thanks. So I think that the most obvious place where that's happening is actually in a body of work that I didn't talk about today, which is in the testing space. So I've had I shared with you projects I've had in Alabama related to the EHE supplements around PrEP. I've also had a couple of studies around trying to figure out how to increase HIV testing across the state and how to do a better job of trying to get testing outreach to happen where it's needed most. So some of that work is around thinking about mobile-based HIV testing, which hasn't been a big part of rural America's HIV response at all, but has been a huge backbone of HIV testing outreach in sub-Saharan Africa, where it is more rural and where things are spread out and where there's really limited access to health facilities. So I've taken some of what I didn't do HIV testing work in South Africa, but many of my colleagues, and so some of the work learned there, we've applied that to partner to HIV testing mobile programs with Montgomery Advocacy and Outreach in Montgomery, and in a new project that I'm doing with Adi Arana and others in Mobile County. That's one. I think that I'm still kind of wrapping my head. It's funny, like I'm a practicing infectious disease clinician, but I'm not an HIV provider in the US. And so I'm still wrapping my head around all of the very complicated layers that go into the healthcare system that provides HIV care in this country. And I feel like, it's not so innovative, but it's a lot simpler in the public health context in South Africa, where I've worked in South Africa and Uganda, in Rwanda. It's not perfect there either, but it is simpler. And so thinking and figuring out, like, are there opportunities to simplify our systems is, I think there's room for innovation there. It's just so very different on so many structural levels. I think there's also, I think there's a lot, I didn't go into as much as I could have around all of kind of thinking about like PrEP adherence in women and how to measure it. I think it's really different by context and by physiology. And so I think there are opportunities for innovation there as well. There's just much more data for PrEP for women using PrEP coming from sub-Saharan Africa than from this country. And so thinking about how to innovate to optimize what we can learn so that we can know more sooner is important.
Great, thank you.
It looks like there's a question in the chat. Or not in the chat, I'm sorry, in Q&A.
Oh, in the Q&A. Allison Spenceley says, I wanted to ask about the applicability of some of the adherence strategies that are used for treatment, things like buddy systems, and if they've been tried with PrEP use in women. I would say that most of the adherence strategies that have been used for treatment have been tried or are being tried for PrEP in women. The bulk of that work is being done in sub-Saharan Africa, where the number of women affected by exposed to HIV is just higher. And things like adherence clubs, text message support, getting that drug level data, giving drug level feedback to women to say like, hey, it looks like you're having a hard time. How can we help you? Cash incentives are some of the many things that have been tried to promote PrEP use. I think buddy systems maybe have happened. I can't actually think of a specific study that's tried that, but a lot of things. I think people are definitely, the people who study treatment adherence are now studying PrEP adherence. So I think we are using a lot of the same things. So there's a question in the room.
Hi. It seemed like from some of the data you were presenting in the South African and Ugandan context, that total fertility rate, or maybe somewhere in there, that the likelihood of someone being pregnant near or during the study was pretty correlated with adherence, and maybe even motivated that. And is that so? I guess the first thing is like, is that possibly something that would be a problem here in the U.S., where fertility rate is more like South Africa than Uganda?
Yeah. So one of the interesting that our pregnancy incidence in South Africa was quite low, as you saw, and it was kind of lower than you would expect based on population estimates. If you look at a population of women who say they want to have a child in the next year, I expected way more women to have a pregnancy than what we saw. I think that our study was one of the first PrEP projects, it was the only PrEP access project happening in the community where we were, except for there was one project happening for sex workers. Other than that, there were no other opportunities to access PrEP. So I actually think we had a lot of people coming in who wanted PrEP, who knew they should say they wanted to have a child, but actually didn't really want to have a child. Also, in our qualitative data, we had a fair number of people who said that after the safer conception counseling, when they realized we didn't have like a super easy way to get pregnant and not get HIV, they were like, maybe I'll wait. Maybe this isn't the time. So I do think that our pregnancy intention rate was higher in Uganda and sustained in Uganda, and that may have contributed to some of the motivations for using PrEP for sure. How to translate that to a US context, I think that if we're targeting people who are trying for a pregnancy, and you're doing that clinically, I don't think you'd have as many challenges with people who don't actually want a pregnancy coming into that. That's a good question. Great. Well, I put my, I think you can all find my contact details on those slides, or through Cameron or through the Sparkman Center. If there are more questions, happy to take them. And thanks again for inviting me to share this work.
Thank you so much. Thank you so much, Lynn. And I think we're all excited to learn more and to keep following this work that you're doing. Thank you.
Thank you.
Yeah.